years, we all strive to, at one time or the other, better the quality of our clinical encounters with patients. And communication is the bedrock of everything we do in the practice. So truly, this is important. But with special focus on encounters where strong emotions, stressed families, and uncomfortable conversations may need to be held. Nobody receives training for this. I will delve into it as I go into, further into the presentation, beyond the one that we're taught at medical school about taking Nasoran, history, physical examination, differential diagnosis, and all of those. Nobody actually prepares us for encounters where we may be dealing with stressed families and an uncomfortable conversation may need to be held. It also will try to present you a fairly easy to follow framework or protocols which have been proven to facilitate effective physician-patient communication. So truly, I really believe and hope that we'll be able to achieve that at the end of this presentation. Following this brief outline, introduction, which I think I've basically already done, communication and everyday consultations, then with the special focus on breaking bad news to patients. I would also briefly talk about delivering news of death to family. These are two different things. A lot of us think breaking bad news is just telling a relation that someone has passed, has died or not. But there are two different things, as we'll go to see on in the presentation. Then we'll talk about obtaining informed consent and then briefly my references. So what is communication? Quickly, it's a crucial component in all steps of the healthcare process I put here. But the fact is, it is a crucial component in all aspects of life. Except you're a doctor that plans to live in isolation in an island somewhere. In fact, you may need to communicate with the animals around you, even if there are no humans around you. So we all communicate daily in our personal lives with our spouses, our children, our Migadi, people around us, our colleagues. But in the context of the healthcare process, it is particularly important. It may not be important depending on the area you decide to specialize in. If you decide to specialize in pathology, for example, you don't need communication so much. You're not planning to talk with your autopsy patients. Or if you are going to be doing something with slides and tissue, you may not need to communicate. But if it is the actual clinical practice, you would need to perfect and hone your communication skills. It is also the response you get or the information you receive when you send a message. The emphasis here is regardless of your intent, meaning that they say you are judged based on your actions and your words. Nobody ever judges you by your intentions. Nobody knows what is in your mind. You know what you want to get across, but at the end of the day, what is passed across is dependent on what you say and how you say it. So no matter how good your intentions are, you will not be judged on that. It is also important because it is strongly linked, when it is poorly established, it strongly links to adverse effects and, in fact, medical errors. When this is done between colleagues, when communication is poor, medication errors, adverse effects are more likely to happen. It's also key because patient outcomes depend on an accurate transfer of information. It's not just come to the hospital and go out. At the end of the day, what has been passed across in a consultation? It says here that ensuring patients receive proper care involves more than performing procedures and making diagnoses. While it is important that the need of what the patient has come to the hospital to do is achieved, which is probably get a diagnosis, get treated for their ailments, it goes beyond that, especially in a hospital like Limi Hospital, where we want to make every consultation a delightful experience. So it goes beyond just I've made the correct diagnosis or I've done the right procedure for this patient. How has it been done? What was communicated? What is the transfer of information? And here, this next point is very, very, very key. It's been found that the lack of communication is the commonest cause of litigation worldwide. So one would think it is a negligence or, medical errors or anything that causes more of litigation. But the commonest cause is actually lack of communication. Somewhere along the line, the communication broke down and the patient felt slighted and cheated enough, or the relation felt cheated enough to go to seek recourse with the law. So a lack of communication is the commonest cause of litigation. Another reason why we all need to sit up, because we know litigation has come to our shores and has probably come to stay. Then formal medical training, like I said earlier, offers scant preparation, especially for daunting tasks such as breaking bad news. I don't know this. I wasn't taught. I don't know what's happening in medical schools now. But I don't know, I wasn't taught anything along this line. So there's a knowledge gap, a skill gap in this. So it's important we have this. So in Limi Hospital, we have a 5-pronged protocol. The first 4 we know. I'm sure everybody here knows what this is about. The first 4 is mainly between inter-colleague, intra-hospital communication. And the last is basically what we do with our physician-patient interactions. But there's also something that worldwide has been found. This is a mnemonic, or let me say a protocol that can guide us if we can remember in every consultation we may have. Class, just think of class, okay? Just imagine that, okay, it's a class I'm going to have next with this next patient that is coming inside. What are the things that can help me? These 5 steps that can help me remember that as much as possible, I not only transfer information accurately, I have made that consultation a delightful experience. C stands for context. We'll discuss briefly about each of them. L for listening skills, which is talking about how to be an effective listener. A lot of people say, okay, a doctor needs to be a good listener. But beyond being a good listener, the next step is being an effective listener. We'll see what this means as we go on. A is for acknowledge, which is talking about validating and exploring, addressing patients' emotions and concerns as they may arise within that consultation. S is strategy. S and the 2 S's actually, to me, they're practically the same thing. You have formed the strategy, you have a treatment plan, a management plan that the patient can understand. And summary, which is summarizing and clarifying the conversation so that the patient understands what has gone on. It's not just you that understood what happened in that 5 minutes that you used. Both you and the patient understand what has gone on. This is rather small, so please pardon me. Talking about the context, which is the setting. Now, before I talk about setting in any of these communication skills we talk about, it goes beyond the physical space. They are honing more on the physical space, which I'll give the parameters. There's also something called your mental milieu before your patient comes into the consulting room. What is your head space like? We all know that there are barriers to effective communication. There are personal barriers, emotional stress, psychological stress. It's a busy clinic. I'm going to have to see 25 patients today. How am I going to give the best? How am I going to make each experience, each consultation a delightful experience? We understand and acknowledge that these are barriers. But as much as we have come to work that day, you need to set your head in the right space. Make sure that your head setting is also, I'm sorry I'm using setting for our head, but you understand what I'm trying to say. Your mental space must be in the right place to actually have a good consultation with your patient. Next is the physical space now, which is the context that we're talking about. Choose an area where you can have a private conversation. Limi Hospital actually tries in this, that we're not doing corridor consultations. We're not doing consultation in rooms that don't have doors, that anybody coming to and fro can pass and see you inside. So we talk about choosing an area where you can have a private conversation and as much as possible, eyes at the same level.
Let me adjust the screen.
Okay.
Just a moment.
No problem.
Okay.
But I need the yes, so because this is not working, the keyboard is not working. So I'm using a mobile. Okay, just do that. Okay, it's working now. Thank you. So eyes, you need your eyes to be at the same level as that of the patient and family member as much as possible. Why is this important? Before, the model of medicine was paternalistic. You're talking down to your patient. You know better than your patient. They are not really, they are just a body to diagnose and send out of your office. But we have moved from that and we've moved on to the patient-centered model of care, which means that the patient should feel on an equal, it's not a power play in your office. You are there with the patient, but the patient has, without the patient, you wouldn't be there. So I, at the same level, ensures the patient feels a sense of ownership in that consultation as well. So it is not that you're sitting up. In fact, it says that sit down as much as possible. Just have a seat so that you're at the same level. Then there should be no physical barriers within you. Now, I know a lot of people say, no, not in the era of social distancing. We understand that we're in strange times. And we pray that someday we'll go back to our normal times. But ideally, there should be no physical barrier between you and the patient. But if there must be a physical barrier, at least a desk, and they'll be seated across from you. If they want a family member around, of course, the patient should be seated. If a family member is going to be around and the patient is not a minor, the patient should be seated closest to you. This also gives the patient the impression that it is about them. It's not about their family member that has come and accompanied them to the office. So in the sitting arrangement, keep the patient closest to you. Your body language, you should present a relaxed demeanor. Maintain eye contact, except when the patient becomes upset. This is important because in some cultures, when somebody is upset and you keep looking at them in the eye, it makes them even more upset. So present a relaxed demeanor, which still takes us back to the same thing, our mental setting I spoke about earlier, our milieu, your mental milieu. If you're not relaxed, it will show. I saw a video today and I started laughing, something online, and they showed American doctor versus Nigerian doctor. And the American doctor is supposed to be a gynae examining a pregnant woman. And while he was washing his hands and wearing his gloves, the Nigerian that acted it, he went on, I was saying, Madam, welcome, how are you? How's the baby? How's your husband? Oh, I saw you last time. What has happened between that time and now? And you know, there was no patient, it was just an imaginary scenario. And then they showed versus Nigerian doctor, and the same guy acts the same part. And he's doing like this. Why is this AC leaking? Nurse, come and carry this thing from here, it's leaking. Why is this whole office smelling? Hey, madam, what do you say is wrong with you? Why are you always coming every week now? What has happened again? But your baby is breathing now, and you know, it's touching an imaginary tummy. So, you know, these are stereotypes that go around. We know that there are barriers to, you know, ideal consultation settings in our environment. But I know that Limi Hospital at least tries as much as possible to give you that ideal consultation environment. So your body language must be right. Touch. Now, speaking about touch, please, if you must touch a patient, only touch a non-threatening area, like the hand or the forearm. You're a male doctor and you are trying to get familiar with your patient and you're touching close to the chest. It's a threatening touch. Or even if you're a female and you know, there's some context that you should be wary of, even in your touch and trying to connect with your patient. So you need to be aware of cultural issues that may not allow touching. People that practice in Islamic countries, Arabic countries are very conscious of this. Moving on, sorry about that. Now, talking about being an effective listener, which is the L. We said C is the context. L is listening skills. We use more of open-ended questions. We should try as much as possible to ask open-ended questions and not close-ended questions. I'll be giving examples of phrases as much as possible as I go on in this teaching. How did you manage with the new treatments? Okay, so last time you were here, madam, we started you on this kind of medication. How is that going? Or how have you been feeling? Or could you tell me more about your concerns since the last time we saw? So all of these things help in you becoming an effective listener. You're not asking close-ended questions like, so since you started, madam, any headaches? Or are you feeling dizzy? It narrows what the patient can talk about to what you have asked. But if you, even within the constraint of the time that you have, if you use more of open-ended questions, your patient tend to tell you more that way. Then while they are talking, you need to facilitate their talking. You are listening to them. You need to let them know that you are listening to them. You need to allow them to speak without interruptions, nod at times to let them know you are following them, and repeat a key word from the patient's last sentence with your own first sentence. Oh, so you noticed that you've been having nausea and vomiting. So the patient understands that you have actually been listening to what they are saying and they're not just speaking to themselves. If you need to clarify in the process of listening, you can use phrases as, so if I understand you correctly, you are saying that, or can you tell me more about that? You're clarifying. So you have gone from context to listening, and in that listening, you are trying to clarify what they are saying. That's making you an effective listener. Now, in speaking of time and interruptions in the middle of your consultation, if there are time constraints on you for that consultation, as much as possible, let the patient know ahead of time. You're welcome, after you've identified the patient, you've introduced yourself, you need to let them know that you can say things like, okay, so today is a rather busy clinic for us, and we're a bit time constrained. You can see before it was your turn, there was a lot of people behind you. I still want us to achieve as much as possible with the little time that we have. You may even get an idea of the time. How about 15 minutes to see you? It's nothing bad about that. Even abroad, when they make book their consultations, they know how long it will last. So, I have like 15 minutes to discuss with you. So let them know that there are time constraints so that they don't feel rushed or they don't feel like you didn't even listen to them. I went to the office, I came out, that doctor barely listened to me. Talking about pagers, we don't use pagers here, but we use phones. It is said that you should not answer except if you must. If you must. Now, this if you must, I know it's a gray area, but I'd say the only instance under which you must be picking calls is if it's something to do with take care of another patient somewhere else, and they need you to respond urgently. If it is something that can wait, you wouldn't want to be a patient, like Dr. Iseko said in the group today, said there's nothing separating you from there's nothing that's stopping you from being the person across the desk from you being a patient. You wouldn't want to be a patient and you're talking to your doctor, you're trying to get your concerns across, and he or she picks a call and they're talking about Ashwebi or talking about what is for dinner that night, talking with your spouse and say, well, would you rather have you know. So even you would know the calls that are wrong that you should not be picking at that time. So we say don't answer if you must. In fact, silence it so that it vibrates. You notice that somebody has called you. Even I am guilty of this. There's some calls that I rate as very important, but as I go on, I notice that it's actually wrong. I wouldn't want to be on the other foot where somebody is consulting with me and they're talking about something related. Oh, you can take the tire to the mechanic now. Or okay, pick the car up. No. Try to prepare the patient if you know you are going to be interrupted. If it's something that you know that will interrupt you in the course of the consultation, please let your patient know. All of this gives the patient that sense of importance that, well, this person regards me as a person. They're talking about the CLASS. A is acknowledging the emotions, which is what we say you need to have an empathetic or empathic response. What does that mean? So you have listened to them, you have identified the emotions or concerns and the cause of it that they have raised. You respond by showing that you have made the connection between what they are complaining and the cause. Okay, things like, you have a complaint when last you came here, you went to the lab, you spent too long. So you need to acknowledge to let them know that you understand that that's what they're complaining about. That must have felt terrible when you went to the lab and you spent 1 hour before they could take your sample. Or I understand that most people will be upset about what you're complaining about. Let them understand that you have acknowledged what they're complaining about or their concern. Now, notice that in the empathetic response, you don't have to have the same feelings as your patient. You don't even have to agree with their feelings. An empathetic response doesn't mean that you're on the side, oh, everything you say is correct. They're difficult patients, I understand. So empathetic response just means that you don't have to agree with them, or you don't even have to feel what they are feeling, but you make them feel acknowledged and heard. Strategy, what is your plan? You need to propose a plan that the patient will understand. A patient should never leave your office and not know what went on. What is the way forward? Was there a plan? If it means you need to clarify it in your mind first, and then check that the patient understands and is on the same footing with you. It cannot be overemphasized. You need to decide by yourself. That is why you are the physician they have come to see. Describe what the best medical plan will be for the patient. Recommend a strategy on how to proceed. Evaluate the response to that strategy. So I want us first, okay, we're not going to treat you straight. I think it may be this, maybe that, but let's run some tests. You know, then you evaluate. Do they understand what they have said? Collaborate, meaning that they may even disagree. Doctor, I don't want to go to dietitian yet. I think I'll rather try by myself. Okay, you strike that out of your plan. You collaborate and agree on the plan going forward. And of course, summaries, you have to close the interview. Okay, so we're done here. So this is what we have said in this consultation and the physical examination. I've come to this conclusion. This is our plan. Then you need to make a clear contract for a follow-up visit. I'll be seeing you in a month. I'll be seeing you in 2 weeks' time, whether I'm here or somebody else, but we'll need you to come back. All of us are familiar with instances in which a patient comes. They have been found to be hypertensive. They were given medications home. Because there was no clear contract for a follow-up visit, the patient finishes the medications and assumes that that is the end of it. And they go around with their through-the-roof blood pressures, thinking everything is fine, till, as the fate will have it, you may be the one on duty the day they come back with a stroke or something. And you cannot, in all conscience, open your mouth and say, but you defaulted follow-up. Did you make a follow-up plan with that patient? Did you actually let them understand they're supposed to come back in a month's time? Of course, some you will tell that I never come back. Then it's up to them. But please be sure that you have made a follow-up contract with your patient before they leave your office. Moving quickly on to breaking bad news. It is one of the most difficult tasks a physician will encounter. If you practice long enough, no matter how fantastic of a doctor you are, genius of a doctor you are, there'll be instances in which you have to break bad news. It is said in medical circles that when you need to break bad news, as much as possible, it should be broken by the most senior or most experienced person on the team. So when I see that, I actually smile. Because why? All of us, I don't know whether I'm the only one that feels this. I'm caught in a time warp in my mind where I remember exactly when I was 8 years old. I was in primary 3. I was having my birthday. And in my mind, I'm still that girl. But the years have flown by. Such that even though in my mind I'm still that 8-year-old girl, I remember the color of the dress I wore that day to school and the party that I had. But I'm still the person that is the mother of another 8-year-old child. And I'm wondering how, but I'm still a child in my mind. How did I become this person that is now an adult that has all these responsibilities? So my point is this, that if they said the most senior person in the team or the most experienced person, someday, if you do not know how to do these things, you will be that most senior person and the most experienced person on the team that has to be faced with this responsibility. If you don't know about doing it, it's going to be too bad. So the earlier we start practicing it, the better. In fact, there's a slide where I talk about in medical institutions where they are training, it's a teaching facility. They say mentor a younger colleague, a consultant or somebody, or a senior registrar, mentors a junior colleague who participates in that process so that they are trained in it going forward. And what is bad news? It's just simply defined as news or information that may alter a patient's view of his or her future and result in persistent cognitive, behavioral, and emotional responses. Now, ultimately, who decides it is bad news is the patient, it's not you. You are just giving them information. But the way they receive it, how it impacts on their life can only be defined by them. Bad news, for example, may include information related to a chronic disease. You're telling somebody, oh, your results are out, and it was diabetes. Now, a lot of people will say, but what is the big deal? It's just diabetes. But you don't know what diabetes means to that person. They are the ones that understand the impact that it has on their lives, and to them, it is grave news. It can be a life-altering illness, such as a malignancy, which is the one most of us know, which is a cancer. But even end-stage renal disease has a life-altering impact on anybody's life. Or it may be an injury that's going to lead to significant change in that patient's life. For example, extensive nerve injury to the hand in a surgeon. You don't think that it's any major deal, but that surgeon knows that that is his livelihood, and that impact on his life makes it very grave news that you're telling him that, well, we have found out there's extensive injury to your hand. So this is the definition of breaking bad news, and all of us must know how to give this thing to patients. Now, there are preferences, there are patient preferences when you're breaking bad news, there are cultural barriers, there are physician fears. There's so many factors that come into play that we'll just briefly talk on. Now, talk about patient preferences. Most patients have been found to prefer to receive such news in person, not via phone call, not via text message, with the physician's full attention. That's the only time when you're telling them, so madam, I'm coming here, please, can you get me a bottle of Coke? No, your full attention in clear, easy to understand language. That's avoiding medical jargon and the use of non-technical terms. And then there should be adequate time for questions. It's not something you can rush. Most patients prefer to know their diagnosis, but the amount of desired details that they want varies among different cultures. It can even be affected by education, age, and sex. Studies have shown that as concerning breaking of bad news, younger patients not only want to know the diagnosis, they want to know more details. So what are my treatment? At once, the female gender, females generally, they are more interested in knowing more about their diagnosis. The higher the level of education of the patient, they want to know more. And then in some cultures, they don't even want to know so much. So this is my diagnosis, thank you, is enough for now. So you as the doctor, you need to find out what your patient's unique preferences are and apply it going forward. And they've said that even among patients who desire details of their diagnosis and treatment options, many patients are not interested in a specific diagnosis, a prognosis. So let's keep that at the back of my mind. You're not under any burden. You need to know whether your patient is interested in prognosis before I start talking about, so with this diabetes, we think you can survive for the next 10 years because of the, no. Not everybody wants to know. So you as the physician have to decide how much the patient wants to know and when. Physician fears, we have fears ourselves when it comes to breaking bad news. Physicians may experience stress. Before you even discuss the thing with the patient, there's already some stress in your head. How are you going to say it? Because you're afraid of you may be afraid of eliciting an emotional reaction. You don't know how the patient will take it. Some physicians are afraid of being blamed for the bad news, and even how you're going to express your own emotions during the process. Physicians also have been found to withhold information or are overly optimistic regarding prognosis. And you should know that this can lead to confusion for your patients because you have just withholding information. You don't want to give them everything, even though they're asking for it. I have a friend, she's late now, but this was her own scenario. Because the fact is, although bad news may initially increase psychological stress, full and accurate disclosure may help the patient and family make the best time that is left for that patient as possible, meaningful as much as possible. She didn't know. She just kept coming to National Hospital. She was being treated for breast cancer. I wanted to tell her because I knew it was metastatic. But the oncologist never had that discussion with her. So I kept saying, why don't you go back to Port Harcourt, where her family was, and spend time with your little children and your husband? And she kept saying, no. They said, if I can just get 3 million for the next treatment, and she and her husband, they kept raising the money till it was too late. And she barely had, time to really spend with her children before she died. So even though we're trying to shield the patients, sometimes they need to know, of course, when you have gauged and assessed how they want the information. We'll talk about how to do it later. There are different models that help us with how to break bad news. There's the ABCD. They are all mnemonics, actually. breaks and spikes, they're all examples. The spikes protocol is one that is mostly used. It started from being used in oncologic settings, but we find that it has easy reproducibility even with children and non-oncologic settings. They all have something in common, all of these protocols. Talking about establishing a rapport, you notice that it has a lot to do with the class I talked about earlier, but it is now modified to deliver bad news to patients. So you need to get an established rapport in an appropriate setting. You need to determine the patient's previous knowledge and desire for details, avoiding of medical jargon and euphemisms. You need to be able to support your patient's emotions, allow for questions, and summarize and determine the next steps. This is a picture that I put here for breaking bad news. Even though that we all recognize ourselves in this picture, we are the one in the white word coat holding the patient. You can see she's touching the patient's knee. Nobody ever prays, but the tables can always be reversed as well. We may be the one on that other side, God forbid. In Africa, I would say, God forbid, someday having bad news delivered to us, you know. So it's really something that can happen. I don't know whether anybody has noticed that there's a box of tissue on this table. They say it's only people that do that, but the tissue they give you in Limi hospital is not for just wiping your face and wiping your hands. Some patients actually break down in your offices, and it's nice to just offer them something to, you know, as a show of compassion. This is the spikes protocol. This is what I'm talking about. I said it's mostly used all over the world for breaking bad news. S means setting. P is perception. I'll talk about each of them. There's a table I made for each of them. I, invitation. K, knowledge. E, emotions. And S, summarizing. Now, talking about the setting. The key point under the setting is, once again, prepare your mind. Back in the day where HIV was a scourge and a major dread, and nobody wanted to have HIV, we've heard stories where they broke the wrong news, wrong result to a wrong patient. And some patients even committed suicide. And then later they found out that it was not even for them. So is this the right patient? Is this result conclusive? How are you mentally prepared to give this information? Those are the things you need to get in place before the physical setting once again. Arrange for a private room or area. It's not a busy place. Have tissues available. You saw in that picture. Limit interruptions and silence electronics. If you just finished examining the patient, you may need to allow the patient to dress. Not me, you should allow the patient to dress up. Nobody wants to be given bad news in a vulnerable position. They are still barely dressed and you're giving them bad news. Maintain eye contact. Defer chatting. Include family or friends as patient desires. Now, example of phrases that come to play in setting that helps is, you can say something like, oh, madam, so before we review this result, is there anyone else you would like to be here? Some people will actually tell you yes. Although here, that raises a red flag because you say, if they are telling me what do I want to be here, I already know that it's bad news. But it helps them decide whether they want to take it alone or they want, okay, there's something you want to discuss with me. I want a friend around. Okay, let me call my friend or let me call my husband or anybody. I want my mother to be here when I receive this news. Please always check the setting. Like I said earlier as well, before we break bad news, there's another thing we need to. I've had a patient in this hospital who was in a very bad way for 2 weeks. Why? She saw a doctor in this hospital who examined her. She had been having some PV discharge, she's postmenopausal. And at the end of that consultation, the doctor that saw her was convinced it was cervical cancer and had not sent for pap smear yet. So she was going to send for a pap smear. But she had already started telling these patients about how she will support he or she, that's the physician, will support her through the diagnosis, you know, made the patient feel as if it was a done deal. This is a diagnosis already. So in the 2 weeks before the pap smear results came out, she became very, very, very anxious. She could not sleep. They had been calling night vigils. Her family all over the world were already on a prayer chain. And the pap smear came out, fine. So before you break any news of grave import, let's always be sure. In fact, what we say is let a senior person do it. But you may find yourself as the most senior person one day. That's why we're having this discussion now. So please be careful. Then, there's another phrase says, if it's a patient that was on admission, I want to break the news, just to show them that compassion, you may say, would it be okay if I sat on the edge of your bed, just to make them feel you are with them? Now, perception, that's you now checking for what the patient already knows, what their perception of what is going on, before you drop it on them. So you use open-ended questions again to determine their understanding, correct misinformation and misunderstandings as you find out, and then you identify wishful thinking, unrealistic expectations, and even denials that they may already be in before they have heard anything. So example of phrases to use in perception will be when you first felt that lump in your breast, what was your first thought, ma? Or what is your understanding of the test results that you have done so far? Just to check where they are at before you tell them what is happening. So perception, then invitation is now you want to tell them the information that you have. Before you tell them once again, you have to determine how much information and detail they want. You have to ask permission to give results so that the patient can control the conversation. You can say, okay, can I give it? I'll give you the example of phrases to use here. And then if the patient declines, you have to offer to meet them again in the future when they are ready. Some patients will give you and say, okay, so there's something you want to tell me. Can we not discuss it now? Can I, I just want to get some things in place before we have it. Another real quick, I like talking about real life scenarios. So there was a time I was here. Dr. Also, you remember this case. And a mother came in with her daughter. The daughter was quite big. In fact, I looked at the name on the file and the age, and I saw 12 years old. So I assumed, who's the 12-year-old? Because they were almost the same size. So I said, oh, so who's the patient? The brother now pointed at the girl. I go, you're 12? Okay, you're welcome. She was quite big. She was in GSS 2. So the presenting complaint was mainly polyuria, polydipsia. You were not around, Dr. Ofusei. So I think I discussed this patient with you. Polyuria, polydipsia, she had been losing weight. She had been having a lot of recurrent folliculitis in the armpit, So I was really thinking, could this be diabetes? So I now said, okay, noted, examined her, said, okay, can we just do these tests? The mother said, please do any test you need to do. So the father and I are worried and really want to know what's going on. So please, let's go and do them. So I wrote the barrage of tests for them. They went to do it. In fact, they paid and did everything. So by evening, I think most of the results were out. They came back. So they sat down again. And of course, the random blood sugar was over 400. The glucose, glycosuria 3+, a lot of things was very deranged. So I didn't really assess the situation properly, because if I had, I would have found a way to first maybe talk to the mother first of all. So I just broke it there that, okay, so the results are showing that, this is very likely to be diabetes. From the result, the sugar is high. And the 12-year-old broke down there in my office. She said, can I be diabetic? It's not possible. I'm just a young girl, I'm just a little girl. And she was weeping and, the mother had to actually take her out. Then the mother came back alone and she was quite reproachful. She's like, doctor, don't you think it would have been better? Maybe, since she's a minor, you would have, had this discussion with me first, and then I can bring her in and would have prepared her mind for the discussion. So that didn't go well. The fact is I bungled that breaking of bad news. There are ways you can actually check these things, invite, even if she had come with her mother, I could have said, okay, Mariam, that was her name. Can you just excuse, I want to speak to your mom briefly. Just find a better way to handle that scenario. So, example of phrases you can ask there is, would it be okay if I gave you those test results now? Are you someone who likes to know all of the details at once, or would you prefer that I focus on the most important detail for now? Those are invitation questions that I can ask that helps you set the tone of what you're going to say next. And that's the knowledge. That's the one you're giving them information. So you need to briefly summarize leading point, events leading up to the point. If you need to, not in all instances, you may need to provide a warning statement to help lessen the impact of the shock on them and facilitate understanding. Like I said earlier, try and avoid use of too many medical terms and jargon so that you don't confuse the patient. They don't even know what you're talking about. And then stop often to confirm understanding. Example of phrases here is, before I get to the results, I'd like to summarize so that we're all on the same page. Or you can say, this is a warning statement, for example. Unfortunately, the test results are worse than we initially hoped for. Those are just opening statements. So that the patient knows that what is coming next is not really nice. You can say things like, I know this is a lot of information. What questions do you have so far before I go on? Then emotions, of course, it's going to elicit an emotional response. Stop and address emotions as they arise. Use empathic statements to recognize that emotion they're showing. Validate responses to help the patient realize that their feelings are important at that point in time, and ask exploratory questions to help understand when emotions are not clear. You can say things like, I can see this is not the news you were expecting, or you can say things like, yes, I can understand why you feel that way, or could you tell me more about what concerns you right now? And lastly, summary and strategy. You need to summarize the news to facilitate. No matter how emotional the patient got, you still need to summarize what you have said so far. You need a plan. No patient should have bad news broken to them, and they have left your office and they don't know any plan. You just left them crying. After they have addressed the emotions, You need to make a plan. So we're going to be sending you to so specialist, or we're going to be doing so further tests to confirm. You know, you need to give them options. They must not leave your office hopeless, no matter how poor the prognosis is. Offer a means of contact if additional questions arise. Avoid statements like, there is nothing more we can do for you, just go home and die. No, please. Example of phrases I used to hear is, I know this is all very frightening news, and I'm sure you will think of many more questions later. When you do, could you write them down and we can review them when we meet up again later? Or things like, even though we cannot cure your cancer, we can offer you control, pain control. We can lessen your discomfort. There are things you can provide that can help out. In more developed centers, you can offer them hospice, there's palliative care, you know, they have more things there. But here, there are also things you can offer them still. It's not go home and die, it's over. The key point to summarize all this that I've talked about is 4 main things. Provide a setting that assures privacy. Limit interruption and involves family if the patient desires. Some may not desire their family to know. Use non-technical words and avoid medical jargon. Provide empathy. Please avoid being blunt and respond to patients' emotions as they arise. I'll be going on to delivering news of death. That's what a lot of us think of as breaking bad news. They are not the same thing, like I said earlier. Delivering news of death just means the patient's relation has died and you need to discuss with them. I just put up a picture here of a doctor who is supposedly breaking news of death to a couple. Nobody ever wants to do this. In fact, I think a lot of us run away when this happens. We just kind of find a way to give the environment. But you know that with this presentation, you find that you cannot. Get it right the first time. You don't have a second chance at delivering news of death to your family. You must get it right that first time. Because like I said earlier, if you don't get it right, it is the commonest cause of litigation and all over the world. Talk about the key points of introducing yourself, identifying all participants where you're going to deliver the news, assess their relationships with the patient, and identify level of understanding before you go on. The doctor must deliver the news. I'm raising my voice. The doctor, it cannot be delegated anywhere in the world. A patient cannot die and you say, please, as an anesthetist nurse, please, can you be the one that tells them? No. It's been found that in instances where someone else on the medical team other than the doctor is one that delivers the news of death, the family tends to think that their loved one did not receive the highest level of care. Why is it that it's the nurse that is breaking this news? Where is the doctor? So you cannot delegate it, so you know you need to know how to do it. You can get a support person who can remain longer. Maybe even after you've broken the news and you have consoled them, you can get a second person inside them, like a nurse or somebody that can remain longer than you. You can even be a pastor that can handle the thing better. Or a social worker, where as the case may be. And that person serves as a point of contact. If you must leave the room, this person can remain, like I said, to provide continuity of care. The tone set by the bearer of bad news has a significant impact on the grief response. It is not good news. There's no way you can lessen the shock of it. But the tone set by you are the bearer of bad news in this instance, has a significant impact on their grief response. I said earlier about those in teaching hospitals mentoring medical students or residents by taking them to observe. Most doctors have learned this by trial and error, as most training programs don't address this issue. Dr. Also, I don't remember there was a particular day, I'm talking about it so much today, that we resuscitated a patient together in ICU in central area. And you know, we did CPR, did everything, and the patient's son, I think, was just there looking at us, going in and going out, and I was wondering who is going to do it between me and Dr. Obusoi now. Somebody has to do it, no matter how much you are doing CPRs. Now, this is important because it's been said that the portrayal of success of CPRs on media, that's on movies that people watch and everything, it is twice that's what it is in real life. Meaning that people have watched a lot of movies in which their relation is in the coded blue and they're pressing the chest and, you know, eventually the patient comes back. That studies have shown that it is twice more successful on TV than in real life. So a lot of people already have unrealistic expectations. Oh, you're trying to resuscitate my relation. It's going to come out of it. They may not come out of it. And you have to be the one that breaks that bad news. Why? What is it? It is a necessary part of your job. And you must do it as competently as any procedure. You may need to review your own hospital protocols for their end-of-life issues. You need to emotionally prepare yourself for this task. You must shift gears from a medical expert to an emotional support person. In your usual role, that's as a physician, you can rely on protocols, objectivity, mechanical skills, and all of those things that we all have ready But this role requires interactive skills and empathy. You cannot be a robot. That's why I said that if you know that I'm naturally not a friendly person, I'm naturally not an empathetic person, please go and do pathology. Do something that does not require any communication skills. But even in that place, you have to communicate with your colleagues, I think. So this role requires you to have interactive skills and empathy. View yourself as calm, slow down, and speak in a deliberate manner. Be prepared about what you want to say. You don't go there and start mumbling things up. In fact, know the name of the deceased, not, who are you going to ask for the name of the person you're about to talk about? So you review the events before meeting with the family. Forgive yourself for your inability to be superhuman. You can't be superhuman at that point in time. You're just human. And the fact is you have to give them unexpected news. That is very, very difficult because you may not even know them. They may be strangers to you. The notification should take place in a comfortable private location that is of adequate size. You don't break news of death to people on the corridor. You understand? As much as possible, you should be in a comfortable space that they can actually react as they want to. All ways are not acceptable. Have personal amenities available. No interruptions. Turn off your phone. If bad news, why do we need to deliver bad news properly? If bad news is delivered poorly, there will be no chance to make amends. And it allows the family to initiate the grieving process properly. The family will always associate your delivery of the news and with the hospital and care delivery forever. Forever is such a strong word. Forever means forever. Anytime they pass the front of that hospital, they may be going on an unrelated journey. They look at that hospital and they remember. And they will remember you and how you told them. So it is not something to be taken on lightly. How do you do it? Please wear a clean white coat that is free of blood stains, especially in a traumatic death. They brought somebody with an accident. You have done all kinds of things to tourniquet the wound and they exsanguinated and died. And that same thing that you wore, the white coat that makes you look like you're coming from an abattoir, the same one you wear and go and stand in front of the family, they're looking at you and they're seeing all of that. Please, they say that as much as possible, wear a clean white coat. Enter the room and introduce yourself pleasantly and learn everyone's identity. Try to address the next of kin, not necessarily. So when you identify who's the next of kin, that's the person you need to be addressing, not the person that's necessarily showing you the most attention. Because that may be unrelated. That one is just, but the next of kin has been maybe the wife or the mother or whoever it is, that's the one you're addressing. You can't look at all of them at the same time, so you focus on that person. Give the immediate family the opportunity to receive the news in private. If the family says, no, we want to be alone or we don't want any other person around, give them the opportunity. Sit down to imply that you have unlimited time. Evaluate social support available to the family, including religious and spiritual leaders. You also need to sensitive to families' culture, race, social background, Then for pediatric cases, it's doubly difficult because most pediatric case mortalities the parents always tend to blame themselves. So it's important that you take it very, very carefully. In fact, they say it's better you break it to both parents at the same time so that one parent doesn't have to be bearer of bad news to the other person. Now, please don't use euphemisms like your husband has passed away or gone to the great beyond or didn't make it. These are euphemisms that we use a lot. Maybe you think it will lessen the impact. It is advised that you avoid them. It is important to use words such as your husband has died. It's an active voice rather than your husband is dead. It's not very helpful if you, the bearer of bad news, start crying. So they expect you to be organized, compassionate, and supportive, but there's no point you being also very emotional and start crying. No. Avoid saying things like, I know how you feel. They may ask you how you cope with your own. So you've lost your husband before. How did you cope? This shifts the attention to you and not the family or the patient. Offer them condolences and tell them you are sorry for their pain and realize that they are grieved. Those are okay. Avoid insensitive remarks such as, well, you're still young, you can have another child, or you should be thankful that you already have 2 healthy children, or saying things like, your mother is better off now anyway. These are things that we see, especially in this environment, but studies have shown that people actually resent such statements. Offer them, tell them you're sorry for their loss and all of that, but not, you're lucky yourself, he's no longer suffering, he's resting now. No, you don't know whether he's resting now, so you should avoid saying things like that. Never ever get into an argument with the family. If the reaction is quite overt, that's not the time to be playing the blame game. You didn't do enough and then you start shouting with them. It is not okay. Avoid squelching normal grief reactions, such as tranquilizers. They say they just postpone the initiation of the grieving process. However, if somebody collapses there, the family member may need to become a patient. So it's important. Like I said, like pediatric deaths are more difficult. Then legal and logistics arrangements. You call the deceased by the name. It's not say, so we can release the body to you. You can release Mr. So person to you. You know, so. Offer each family member the opportunity to view the body. This gives them closure. Before they view the family, you can warn them of presence of tubes. While we're trying to resuscitate, there was this, there was that, there, disfigurements that may have happened. You can prepare their minds. Clean the patient, dress the wounds, clean up the blood on the floor, you know, make them presentable, close the patient's eyes, place the head on a pillow. Don't just leave them anyhow, because those things stay with people forever. We're talking about it in fairly academic terms and in an academic setting, but it could be any of us. So, you know, you want to prepare the patient properly so that they see them in a way that they know that they got the best care possible. Offer to call a pastor if they want that one. Coroner's case, some of them are coroner's cases, especially where it's mandatory or suspicious. It's mandatory for suspicious of violent causes of death, or in cases where the patient is not under the care of a physician or is recently post-op. So we don't really do that in this country, but we should be aware of it. We may not always practice here. So in such cases, the coroner's office decides if they want to do an autopsy. Moving fast, lastly, I'll be talking about obtaining informed consent. It is a process in which a healthcare provider educates the patient about the risks, benefits, and alternatives of a given procedure or intervention. The patient must be competent enough to make a voluntary decision about whether to undergo the intervention or not. And implicit in providing informed consent is an assessment of the patient's understanding. That means if that's it's not about just signing. You need to know that the patient understood what you have said, and you're writing an actual documentation of the process. The required elements for documentation of informed consent, because we take it a lot, we should know what we're doing. It's actually a legal document. The nature of the procedure, have you discussed with your patient? The risks and benefits of said procedure. It has risk, you should know. Are there any reasonable alternatives to this procedure? Madam, you need an emergency cesarean section. What are the alternatives? She needs to know. Assessment of the patient's understanding of all the first four things we just talked about. It is the obligation of the provider, you, to make it clear that the patient is participating in the decision-making process, and you have to avoid making the patient feel forced to agree with you. So this is just something that talks about all of this again. Informed consent in the middle, the nature of the treatment, what are the risks and benefits, are there alternatives to this procedure, and then opportunity for questions. Now, talking about, this is actually law. What forms an adequate informed consent? There are three legal approaches that the law uses to assess what is an adequate informed consent. They can choose any of these three, depending on which part of the world you practice in. Subjective standard, meaning what would this patient need to know and understand to make an informed decision? Or maybe you are the type of doctor that does what we call reasonable patient standard. What would the average patient need to know to be an informed participant in this decision? Or the reasonable physician standard. What would a typical physician say about this procedure? Any of these three may suffice when you're getting one. There are several exceptions to informed consent, of course. If the patient is incapacitated, if it's a life-threatening emergency with inadequate time to obtain consent, and of course, there may be voluntary waived consent. Don't worry, just go ahead. If the patient's ability to make decisions is questionable, an evaluation by a psychiatrist to determine competency may be requested if it's not something there's an emergency. Of course, the law also has a pathway for that. If the person does not have a decision maker, they may need to get a legal guardian appointed by the courts. Children and informed consent. You have a child and you need to get an informed consent. So children under 17 typically do not give informed consent. As such, the parents give what we call informed permission, not informed consent. An exception to this rule with children is a legally emancipated child who can provide informed consent for themselves. So I was interested. I said, who is a legally emancipated child? In case I have any living in my house. So a child under 18, but is married, is what we call a legally emancipated child, and they can give informed consent for themselves, even though they are 16. And we can agree that this can happen in the northern part of the country, where there's a lot of child marriage. Somebody serving in the military is less than 18, able to prove financial independence, maybe they're very rich by themselves, and they're mothers of children, whether married or not. So there's legislation about this. In conclusion, basically, communication skills must be honed. We cannot talk about everything today. I'm just trying to set us thinking along this path. Must be honed along with clinical skills. You are developing your clinical skills daily. As you develop your clinical skills, do not forget your communication skills because they make you a complete physician. And it is lifelong. Like I said, I've told you the ones I've bungled recently myself. It is not the most experienced or I've been around longer. I know it to the letter. I'm learning it and I plan to learn it till I die. Regular training like the one we're having today, role play, and of course, institutional audits will go a long way. We check within ourselves from time to time, how are we managing with communication? How are we doing with communication? I know we've had some issues recently, some doctor that was reported. She doesn't make her a horrible doctor. It just means she needs to work more on her communication skills to make her a better physician. And it can be any of us. So all of this will go a long way in perfecting this vital skill. Here are my references. Thank you for your attention. Thank you.
Thank you, Dr. Sankey, for the beautiful presentation. Of course, I'm sure there are questions. I'm sure there are questions, and I think we should type our questions into the chat box. I have some questions myself, so I think I'm going to start. It's going to be at least a bit of interactive part, but let's please type our questions in the chat box. There are tons of them. Just put this button down. So, first of all, I'll comment that part of the barriers we have towards communicating appropriately in clinical settings will include sometimes lack of time, which is a global issue. And then secondly, sometimes healthcare workers, particularly doctors in this case, can get tired or you feel tired and allow our tiredness and fatigue to get in our way. And during that time, unconsciously, your communication is maybe 80% on a normal day, but you find yourself communicating at 30% or 40%, and you're not even aware. It's just that someone will just hear that someone talk like this to a patient, and you're like, this person, okay? And the advice I give for us in situations like that is that we should be especially conscious of ourselves, especially when you're tired or when you've worked for a long time. That's when there's the tendency to actually say, okay, sit down now. No, madam, that's where I say you should go now. Some things that you normally will not say in a certain way. So we should be especially conscious of ourselves as physicians, especially at the time that you know that you're not likely to be your 100%. So I think that's very important. Now going to your presentation now, Chief. The part I'll comment about, of course, is the spikes in the breaking bad news. Most of what's the word now? The examples you used were unubolized. Quite, they're proper, but usually I want us to go through some of these things in ways that would involve the way we communicate as Nigerians, basically. Okay, so in terms of settings, of course, will it be okay if I start at the end of the bed? So the first part I'll talk about is in terms of the setting. Anybody else that you want here? Of course, usually many people want someone to be there. Sadly, these days when we are just allowing one of the spouse just one person, no visitors. Okay, of course, sometimes this kind of times it's time that you have to ask, okay, is your husband around or is madam around? Is there anybody else you want to be here while we talk about this? So that can be helpful. And usually for the man, whatever the man is the head of the family, in this environment, I suspect maybe slightly inappropriate to ask about that, depending on how fit and healthy the person is. But you can imagine a 50-year-old politician that you want to break some kind of bad news and now asks if he wants his wife to be there. I'm just gauging.
Is there anyone else?
Anyone else? I mean, just okay. Well, I think leaving it open like that is reasonable anyway. Is there anyone else who wants to be there? So that's one. And secondly, when we are discussing investigation results, I know that stuff I did. I think a few weeks ago that I told there was a video that we recorded. That someone said, okay, we have a website. Usually it's beautiful, like you describe it, to walk back from the investigation results. In fact, to walk back from the history when we are breaking bad news, okay? So we did that scan for you because you experienced a lump in your breast and we were not quite sure what it was. And we did a scan for you to see whether is this or is that, okay? Can you remember? what kind of diagnosis can you remember us that we were considering at that time? See whether cancer was on the person's list or not. Okay, if it was not there, before you broke the bad news, let remind the person that we're considering cancer. It goes for things like things serious like pulmonary embolism or heart attack too. If we are discussing the results, it's good to work back from the symptoms to the investigations we did and why we are now discussing the investigation results. So that one helps basically. In terms of invitation in this setting, of course, it's always still good to know whether the patient is ready for the investigation results. Okay, but I will wonder what's the best way to phrase whether a patient is ready to receive the investigation results or not. Of course, by the time they come to a clinic, most of the times they're ready, really. But what do you think?
I'm looking for the right words.
The right word or the right kind of statement that's very applicable. Of course, would it be okay if I give you those search results now?
Yes.
Some of my patients, yes, but for most of my patients, no. Well, the truth is that most of them, when they come to the consulting room, if you walk back from that, if they're not ready, you will know. From their body language, they will know. And of course, if you have a patient that seems not ready for that result now, or maybe jittery about the result, let me phrase it like that. Again, I'll go back to that question.
For what you want to say.
Absolutely.
So it's still part of the setting.
True. And of course, if the person appears not to be ready, you might go back upwards to see if they want somebody else to be there. And now that, of course, it goes to some of the other things we've talked about before, but the cultural aspects here, for example, some of these kind of results, in fact, some people say that don't tell mama. Of course, you know that now. Like, don't tell mama, or it's the husband you should tell. For example, there's someone I still have on the ward now. She's aware of the diagnosis, she's aware of many of the things, but we've asked to, or we've been forced to underplay most of the things to her because they feel that she'll worry too much, and then it's the husband that just wants to hold and just smash out most of the information. And so, in bits, so to say, and then the family members want to do most of the muscling of the stuff. Legally, it's not totally correct, but in a culturally sensitive manner, it's still appropriate for many other little things in our settings. Okay, so of course the knowledge part. This echo is annoying me. Is it echo or just a speaker there? Okay, so the knowledge part now.
It's okay.
I think so, but I'm not sure whether it's echoing for other people. So yeah, the knowledge part. Of course, I think the knowledge part is where we deliver the news itself, Abby. I'm trying to remember of the last news I delivered now. Before I go. Okay, so there was a lady. Which one should I use now? Well,
No one is suspecting COVID-19.
well, true, yeah, true. Okay, yeah. Okay, so I think we can use that. Okay, so so there was someone I saw a few days ago that the COVID antibody test was positive, even though later when they did the PCR it was negative. Okay, but when I wanted to deliver it, okay, so we can discuss this, and this goes to things in our environment. So this one I did discuss with the patient itself, number one, because the guy was fairly sick. It was the sister that brought him, who is older, that I discussed with. And I called her outside. I told her, I reminded her of the reason why I wanted to do COVID-19 antibody tests. And then I told her it was positive. Okay, so the reminding her of the reason why I wanted to do it is like taking back from the history because he had fever and a bit of this has not been going over a while. Of course, for bad news, even though this is not delivering deaths, discussing it outside is not good. Ideal place is somewhere that person can sit down, maybe your doctor's office, for instance. Maybe someone's in my office at that time, but someone that asked for it because there was someone I delivered the news to recently, and I actually thought the person was strong enough. The person actually, literally, like this after, sat down, like heavily, like, okay, so that corridor thing you mentioned is important. Of course, summarizing the results is key. The main part of the results is key. What other things do I have to comment about? Okay, yeah, the emotions after. You didn't mention A, yeah, so I was not happy about that. So A, yeah, is one of our go-to words, at least of the second go-to word, and I use it as a go-to word. So like that emotion. So instead of this, I can see this is what we're not expecting, which is quite boyish again. No, and it is well again. It's one of the emotions that talking Nigeria now and Abuja now.
No, but it helps your patients.
Say it again.
If it helps your patient,
Yeah.
looking at the cultural context where we are and the religious context, it is not oversimplifying the diagnosis. It's not giving them false hope.
Absolutely.
It is well because it is a phrase that actually gives them comfort.
Absolutely.
So
Absolutely.
that would still be appropriate.
I totally know. It's definitely totally appropriate. It's definitely totally appropriate.
It is well come before after.
I know after the news, after the news. To console them after the news and to manage their emotion. Because after the news is the knowledge of the spikes that you deliver the stuff, and of course emotions is going to come after. And you must be ready to manage the emotions. And so, of course, the examples given here in this version is I can see this is not the news we're expecting, which is good. I can understand you're feeling this way, which is good as well. Okay, but very practically, it is well, or just some of those slogans can be helpful.
Does anybody have phrases that help?
Which other phrases? After delivering the news to a patient, I'm not saying death news now, but it's serious diagnosis like diabetes, HIV, perhaps even COVID.
Whatever we say, I just know whatever we say should be able to offer some form of hope. Like I said, no matter how poor the prognosis is, you will be able to give them some kind of hope. That there are still things that we can do for you, even in the context of this diagnosis that I just delivered to you. There are things, to say that there are treatment options available, there are management options available, there are things that can lessen pain, things that can help with your discomfort. Maybe I'm an able person in my mind, I just have my skin so down. But I think these things are things I would say.
Yeah, you're right.
That things I would say. And when in Abuja, if I was really practicing in Sankey or somewhere in your state, deep in the bush now, I wonder what would I say? I practice it in local language there, if I can speak it. But this
Another thing again is that sometimes someone that can speak doesn't
That's when they ask for somebody else if they want to receive the news from somebody else there.
And I know that in every language there are different kind of comforting statements that is in that language that is and absolutely. And then in Nigeria there's a lot of religious sentiment. One, I'm not sure what other thing is stronger than religion in Nigeria, and it helps. It really, really helps. Like I don't know. I won't go into that level, but everything that we can leverage on, usually we should leverage on as much as possible. And that goes now to the breaking bad news now. And of course, there are a lot of cultural differences for us. A lot. Okay. Now, yes, technically and legally, the next of kin. Okay. But let's say the next of kin of a man is the son. Let's say he's even 25 years old, he's old enough, he's next of kin. Okay. But the father has a brother that is the uncle. Okay. If the man dies, it's the uncle you face will usually head, of course. And let's say the man that brought him to the hospital. You can't just face the 25-year-old and now leave the man aside. The man that left aside will just, in fact, if the son cooperates, they will say like, okay, I'm be going now, I'm be. So those cultural sensitivities are there, and we'll put them into context. The other ones, of course, is even though, of course, this one is complex now. If it's, let's say it's a man that died, and the man had family members, if the family member, the next family member that is, it depends on the family structure. Let me just put it like that.
Which is why you need to understand.
That we need to understand that family dynamics.
Yes.
And then we just, exactly. And I think that's important that's the importance of that identifying everybody. Yes. Now that identifying does not mean asking them one by one. If someone dies, but at least knowing them and knowing the most important people, and we just work with their family dynamics. Because in some settings, for example, like I said, that if there's a man, also culture, there's a man, let's say the man died, the wife is still, many times there's even many wives, many times it's still the man's siblings, perfect they're around, that would be on the shoulder, because they believe that women should just,
yes.
We're not saying we're supporting that or not, but it's just the structure that is there that will follow.
It's culturally sensitive.
Absolutely. And I think those are my initial additions, my initial additions. So I'll go through some of the questions now.
Okay.
Okay, so Dr. John said that how do we manage physical attacks following breaking bad news?
Okay.
I need to know that this is a how do we manage physical attacks following breaking of bad news? That's a person, and then they try to attack you. Chief, comment on that because I would like to comment on it.
Yes. As a physician.
We're not hearing anything now. Dr. Off, so you put on your mic. Dr. Off, so please ask the presenter to unmute her mic. Dr. Off, please ask the presenter to unmute her mic.
The hospital or get support.
Okay. All right. Sorry for that break. I'm back. So in response to Dr. John's question, asking about how do you handle a situation in which when you deliver bad news to a relation, they may become physically aggressive and even attack you. So I was saying that the responsibility for determining how to break the news also depends on you, the doctor. You already know how volatile the situation is. And in some instances, you may need, in such instances, as much as it's possible in some materials I read, you should get a security guard present in that place. You should stay closer to the door. In fact, you should be the closest to the door in case you need to make a hasty exit, a hasty retreat, because you do not know how volatile or how violent the grief reaction may be. So it is still part of the delivering serious or news of death that you need to be able to correctly assess the situation and prepare for it. I was even telling them about instances in the US where a father has shocked the doctor that delivered the bad news before, the bad news of his child's death. So at the end of the day, it is still you that need to determine what's best and how best to go about it. Any other questions?
Thank you for that answer. Dr. Akofa wants to say something.
Okay.
Dr. Akofa. Okay, so I'm going to just comment further on what you said now, Chief. So I actually believe that even though people are complex and the psychological response to grieving is also complex, but I would add that many times when there's a violent reaction to delivering the news of death, it's actually often because of some perception in the last moments of managing the patient.
Yes.
So that they give them false hope, one, or there is a perception that they didn't do the best for the patient, or there's perception that it's a healthcare worker's fault. So I think at the stage of resuscitation, at that last stage, it's good to carry the family members along.
Definitely.
Slightly reduce the chances of that happening. That's one. And then secondly, the manner in which the bad news is broken to can affect that. Of course, you can't totally eliminate that. I mean, it will always happen.
Yes.
It will happen from time to time. But I think the bad news is broken in the most empathic manner, in the most sensitive manner to the, and of course, you read the relations. And that's that issue with that next of kin. I mean, it's legally the most appropriate way. Sometimes you can put the next of kin there, but I mean, I have several instances in which, in fact, the next of kin, maybe the wife now in this instance, they have to take the person home himself and lie that the person is still. I'm not saying that's the best way to do, but those kind of situations will happen that is the strongest person. Let me phrase
the
it
family.
that person that can take it the most, that will take
that
it,
you are the one to
and they
deliver
will
the
now
news to.
do it small to the caregiver. So
Definitely.
those ones can contribute to it. And violence against all health workers is one of the ones that can happen. But even violence of the victim, or what's the word now, the family members to themselves too can happen. Of course, we've had people that the wife died and then the husband jumped from third floor downstairs.
Yes,
That's
yes.
okay. Some people do something to harm themselves at that moment, just
Yes.
as a matter of expression of the grief, which is one of the things that we need to be watchful for as well.
Yeah.
Okay, I think there was another question. I can't find the question again.
Do you have any questions in house?
Okay, thank you very much, Dr. Moloja.
Amolaja. You're welcome. Okay.
You mentioned that the best way to come about it.
Yeah,
The best way to inform about death is to say, for example, the person has died. I wanted to find out in our environment, is that acceptable
Appropriate.
or appropriate?
Instead of the euphemisms that we talked about earlier.
Yeah, I'm just asking, I'm just wondering.
It is. Because it is, I think, be perceived as a bit blunt and cruel of you to say those things. But it's been found out that at the end of the day, truly the patient has died.
Chief.
And at the end of the day, it's your body language that matters and the way you say it.
You're right, you're right. But don't forget that we use many languages, Yoruba, I'm not sure Hausa. I can say, well, it depends, let me just say it depends. But the euphemisms are allowed, but you have to still say clearly. That
Yes, for avoidance of confusion.
For avoidance of confusion.
What does it mean that they have passed away to the great beyond?
Okay. So,
They have died.
Of course, it's totally inappropriate. I mean, it's the body language and the voice that matters.
Yes,
At the end of the day,
yes.
actually. But the euphemisms, I won't say make it milder because I'm not trying to make it milder, and there's no way to make it milder. But I just know that you cannot go and say, okay, let me say.
Can I say something? Can I say something?
Dr. Isaka wants to say
If
something.
you want to say something. Yes, sir.
Is it okay? So I
I
think
didn't know I was muted. Hello, sir.
yes. So I think that a combination of both should be used.
Okay.
In our environment. Now, if you say it first with using a euphemism makes it feel as if you are trying to be understanding rather than be blunt. So if you phrase the euphemism, you should immediately follow it up with the actual thing. So you might say he has passed on, and then you now follow it up. Actually, he has died. If you say the two of them together, then you now sound sensitive. But if you just say he has died, you sound insensitive. If you say the euphemism, then you say the real thing. So together is probably the most appropriate way for our environment. It's also quite helpful if you know the language of the person and say it in the language of the person. That may also be
Yes, if you can speak.
Thank you very much,
Thank you,
Chief.
Chief.
Thank you very much. But that language, each language has the most.
As a way, the most comforting
culturally
way.
effective way.
Yeah.
Thank you very much. Of saying it. Like in Yoruba languages, what shall I say? Okay, rather than what it cool.
Yeah.
Now, when it's okay, what shall I say? Then after a while, you can now use the word itself for clearance of any.
In fact, would it surprise that in some instances when you use those euphemisms, the patient's relation may be the one that would now ask, do you mean that the person has died? What are you trying to say? So, you know, it may be a way to ease into the conversation, the fact that the patient has died. So if you say they passed away, they say, what do you mean passed away? Passed away to where? And then you say, actually died.
I thank you very much for that. So I think Dr. Seko's contribution is just that. So we can use the euphemism as a transition to use the word, and it shows that you care the way you say it about your own person, rather than just the died. Sometimes make you look very blunt. Of course, we have to express death in the bluntest way, because if someone is dead, the person is dead.
The person is dead.
It's acceptable to preach it. But if you use the term as possible or something, you have to
still say that word, yeah.
For example, if you don't say that in that same passage of someone that
you have not passed.
You have not said it, and the person can still, the relation can still be imagined that maybe passed on means
you went into a coma.
Anesthesia, they will still come out of. So, okay. Any other question from the house, please?
In front of this hospital, that they rushed and the man later died. So eventually, when their bill was related, I don't know the amount, but they were not happy with the amount. So they started shouting and then making it seem. So when you're talking about breaking bad news or that can lead to violence and all that. So in such situation, because they started becoming a bit violent to the people in front desk, and on some occasions they may even come to the doctor's office, because some of them believe that it's the doctor that tells the front desk the price, whatever to do them or to charge them. So by the time they come to you, and then they want you to like try to bring down the price for them as a higher person. So if you don't do anything, they may not find it funny. So in that state of tension and all that, what do you do to calm the situation?
Okay.
No, just to be clear now, this is not strictly about delivering the news of death, because I'll be thinking this is the fallout from the death, from the bad news. You have done your part as a doctor. This is now, I have a story. This is a short story. In my posting, my rural posting in family medicine, I was posted to some place deep in Plateau State, Lantan. They call the place Zamku. And they called me one Sunday morning that a lady slumped in church. She was there for her wedding Thanksgiving. She got married yesterday, and then the next day they were doing Thanksgiving in church. Unmuted, and then she slumped and she died. So they rushed her to the hospital. So by the time I was called to see her, she was still in all her finery. And the people from the church had moved into the hospital premises because they all came from church. They were wearing ashwebi and everything. And I examined her, and of course she was brought in dead. So I needed to break the news to the husband, who was of course hovering, his relations. Her own parents had come from the wedding from Abuja to Plateau for the thing. And I had to find a way to deliver the news to them. But somehow the news got out to everybody that had come. The youth from the community had even followed them into the church. And it was becoming a very volatile scene. Not because the hospital had any hand in the woman's death, but somehow it was grief reaction that was now being exaggerated. They were beginning to want to break windows, break this, break that. And I was the medical superintendent of that place. So I have to find a way to call the police. Yes, I had to involve the police because the closest family members were not even, they were still in shock. They were not reacting. They were just sitting down, weeping, in denial, different stages of grief. But the helpers, the one that loved the one that are crying more than the bereaved, were going to become violent. So I had to call the nearest police that I could get the number. Please, can you just move? And they had to do that. They had to send police officers into the place to disperse the crowd because they're going to start destroying things in a hospital. So this one has gone beyond the relations now. This scenario you're talking about, you have delivered the news to the closest family members, but some other people are, what's the word now? They're not happy with what has happened. They feel they're even going to milk them in their period of grief. In that place, like I said earlier, you involve security because it's now no longer appropriate. It's inappropriate grief reaction, and it may not even be by the most concerned people. So that one now has left your own, is you have to involve security because they can harm people in that kind of situation. They could have harmed me that day. That was what dawned on me after everything after they moved the body. Because they were like, why could she have died? They poisoned her. So is it the hospital that poisoned her? Whatever happened, it was from home.
Okay, thank you for the response, Dr. Sankey. I think it was just basically appropriate like that. Of course, when violent reactions like that happen, many times, I mentioned some things that can contribute to it earlier. Yes. In that kind of public setting, many times, the other thing to watch out for, even though we may not be able to control, is that some places, there's rumors and myths about them before that these places, they kill people there. So anytime when the person was brought in there, they just think, this place again. Yes, when I was working in usage, there was rumors that when we go to usage, they die, and then that means when some people get to, they will just, so some pre-existing mindset, all that plays. But back to the other component of Dr. Frank's question. The truth is that, yes, when someone dies in the process of care, the bills still need to be collected. That's the truth. The bills still need to be collected. And there's nothing we can do about that. Otherwise, if we're thinking the bills will not have to be collected, then that means hospitals and doctors will withhold care because they are afraid that their bills may not be retrieved. They think there's a chance someone might die. And the appropriate thing to do again is what we concluded just now. If anybody is trying to be violent, just involve security.
You don't have the training to handle that.
And sadly, unfortunately, many of our security, at least in this hospital, they are rather timid. Yes, even though they are outsourced and they're supposed to be professional, but they're rather timid. And under such circumstances, I'll tell you that even my own experience has been that they've been rather still timid and they don't impose themselves. Yes. In cardiac care because most of our clients are
affluent,
they just timid house, which is not good. But we're working on that. Because again, if there's that kind of, if there's threats to either the staff or to the hospital facility, the security people should be able to stand up. Okay? Of course, if it gets to calling police level, police should be involved. Thank you very much for that question, Dr. Frank. Okay,
do you have any other question?
Dr. Ibile, Dr. Anya, Dr. Koka. Any other questions? Any other questions from the house online?
Is it ever permissible to break the bad news about maybe a diagnosis in the absence of the actual person involved?
Okay, can you take a scenario?
So, for example, we had a patient who was on admission for a while, had a virus syndrome, and the result wasn't exactly ready until the day she was discharged. She actually left the hospital premises, but her husband promised to come back to see the result. And he did come back, and this was broken without the patient being there. Is that ever permissible?
I think in this context, you have to individualize every scenario. It is not ideal that since the patient is capable, she's not incapacitated, she can actually process the information. But somehow, like Dr. Ausoi was saying, like there are cultural context to these things. He's the husband, he's the head of the home, he's been involved in the care right up until the time of discharge. Implicit in their discharge self is the wife knowing that the husband would come back to, I think I know this patient. To him and not to her. Well, we're in Africa.
In this environment, it is totally appropriate.
Yes,
that's the truth. In this environment, it's totally appropriate. In fact, if you do anything short of that, that's when you see what trouble is.
Yes.
Okay. Some people, in some cultures, the woman should be protected, and of course, if the family understanding is like that and suitable, sometimes of course you can ask the wife that, is that okay with you? That's the best you can do.
Yes.
If it's okay, that's actually the way to go. Because don't forget that the essence of clinical communication is not to take what is legalistically right in the eye of the Westerner or what's going to be appropriate in England. It's actually what is appropriate here and work better for the family units here and give us the kind of outcome
that we desire.
Okay. Of course, there are sometimes when that is totally inappropriate. For example, let's say
depending on the diagnosis.
Exactly, and even depending on the people. Okay, so if you have a university lecturer and wife, and both of them are evaluating people, and the wife came for a test, came to meet you privately for a test, he did the test, and then the husband now calls you and asks for the result. Meaning you cannot.
You cannot.
Okay, but if a couple come, a traditional Hausa couple come, you saw the wife wearing the hijab come, the husband did most of the asking the question.
She's been quiet.
Directing most of the care, and then they told you that when the result is out,
it's the man.
In front of those women, that the man will be the one to come and listen to the result from you. And the wife was there, she didn't doing happy with it. I think it's good to follow
appropriate.
that line. So we have to be culturally sensitive. There's no way we can practice air without, again, in this part of the country, without being culturally sensitive. In fact, you sink very fast. So we have to be culturally sensitive. So in that situation, it was appropriate.
I think it's appropriate.
Okay, but there will be some situations in which it is inappropriate. Okay, and privacy, confidentiality, of course, always has to be respected.
Yes.
Okay, I will tell you that in this scenario, let's say you broke the news to the wife like that, and the wife, I don't know, maybe took it wrong or something happened. Everyone says she committed suicide after hearing it. The family will never take it with you. Not like they may not be able to take it legally, okay, but they won't be happy with you. They won't be happy with you. So we should be aware of the way some cultures work and some families work.
Yes.
Sorry, just one scenario.
Thank you, sir.
What of a situation where a 16-year-old girl, for example, let's say with her father, and then maybe somehow the father just suspected that something was not right with the girl, come to the hospital and say, I want to be pregnant. And then they do the test and the thing is positive. Who do you break it to?
Chief, why are you breaking pregnancy test? Is it a bad news? Just for clarification.
In this context.
Okay.
And he's suspecting and probably threatens the girl that this thing is going to make.
Yes.
So how do you handle that?
Well, I think in this instance, it would be inappropriate to break it to the father. The girl is 16. She may still be a minor, but she can process the information.
Okay.
I want to break down on there small. Okay, so there are a lot of complex things there in this kind of example we gave. Okay, the first thing is that at 16, because 16 is a minor, but is an adult in a setting. At 16, is it appropriate for a father to bring the daughter and insist on a pregnancy test? I'll tell you that I'm not sure what the law says on that, but it's not a very clear-cut thing. Okay, but let's say it's even acceptable. It means that at that time, we still need to get the consent of the girl.
Yes. Patient autonomy still comes to play.
Okay, so let's say the girl has to be carried along that, okay, this is what you're getting yourself into. If she's not really ready psychologically for it, she can actually decline that.
Yes.
And the parents should not be able to force her at 16. Now, at 15 is a different matter, but at 16.
Yes.
Okay, so that's one. And then secondly, at that time that we're running the test, we should, even though she's 16, she's technically a minor, but at 16, the girl has some rights. I'm not just sure what the law of Nigeria says about it, but I know that, okay, anyway, let me continue, Sha. So we should still try to find a way to have an independent communication with that girl. Conversation with that girl.
Where her father is not present.
Where the father is not there, that, okay, the result is like this. Who are we telling? That one should be clarified before that result comes out.
Yes, you should preempt that conversation before the result comes out.
Now, again, I'm not sure what Nigerian law says, but I know that from 14 or 16, at least UK law, they have some entitlements and they have the right to keep some things from their parents, including things like they are using contraceptives, they got pregnant. So let's say a girl of 16 gave you an history of that they've done a initial pregnancy before in UK. You don't have to tell their parents. In fact, if you tell their parents, you broke their confidentiality.
They can sue you.
Even though they are a minor, they are a senior minor kind of that age. It's not that straightforward.
It's gray.
Not that straightforward.
It's not black or white.
I think that it will be. I'm not sure it's appropriate to just can't tell the father like that. But if it's the father that brought, and then the daughter agreed. And I know now.
Of course, it's the one paying.
It makes it much more difficult.
To
Okay.
do.
Well, let's say if the daughter came on her own and did it privately. Of course, we should not tell the parents.
You should not tell the
Only
parents.
ask.
As in to the doctor.
And we should not tell the people.
No,
Tell
we
the
shouldn't.
parents. We just thought that we discussed that with your daughter.
With the doctor.
Okay,
Yes.
and go and meet your daughter to get the information.
Mm.
Okay, but if you came with the parents and the daughter agreed, and you tried to find out, and the daughter was really agreeable, well,
Right.
she has to suffer for, because at that time, I think at the time the results is out, it's already too late to do anything different. Mother will likely have access to that results, and both of them will go and suffer it at home. I'm not sure if any other person has any other views. But
There's a hand up.
I'll just leave Dr.
I didn't
contribution
hand
to raise it again. I don't know, okay, I've seen it, yes. Dr. Kappa mentioned that when we're breaking bad news, if we give warning shots ahead, it reduces the likelihood of it reduces likelihood of violence. That's a violent reaction. But again, it can help you identify early people who is likely to be violent. So that's where he actually commented.
Yeah,
and I think it's
definitely.
true. So if you give warning shots, that suggests that, for me, my own warning shot usually is actually non-verbal most time. But by the time you give warning shot and you see the person like this, you do that. No, let me get someone struck. I can't decide you want to give this bad news. So I think that's a help.
That helps. That's a helpful hint.
I have one experience. Something similar to what I was doing. A woman I saw on the date of the she didn't come back that day. On her next visit, this time with her husband. So they came in together and they were like, what she wants to know about her result. And when I checked, it was positive. So I was a bit confused whether to break it instead of husband
or not.
So I eventually asked the husband to excuse us. The man, though reluctant, eventually
he left.
So I now she broke down and started crying about that. Started accusing the husband. So my question at that point, but she was not saying that if she goes that it was a problem.
Yes.
But for the fact that I asked her to excuse, I asked him that when she goes out, it will cause a big problem between
the two of them.
Try to find out why they broke up.
I think he did the right thing, actually.
Please repeat what you said. I'm sure people didn't hear. People didn't hear. Can you rephrase what? So let me rephrase. So Dr. Aya asked, describing the scenario now.
Simon.
Dr. Simon, sorry. Dr. Simon described the scenario now in which a couple came to discuss the results of a HIV test, and then as he opened the results, as he glanced on the screen and saw it was positive, and the couple was demanding to know the result of the test, but he asked the husband to go out, which he did reluctantly, and then disclose the results to the wife, and then of course she was grieving after hearing the news. So how should that have been handled? That's the question. Actually, what's recommended is that if two people come in for either a clinical communication, even a consultation, particularly if the level of the two people are not equal, if someone appears to have more power than the other, and it goes with the minor stuff, that's 16-year-old and the parents. Actually, what's recommended, that's textbook for ethic people, what they say is that they're coming together, let's say husband and wife come into my office, and the wife is the patient, at least. So what is recommended is that actually ask the husband to still go out,
Yes.
chat with the wife for a bit, and ask her
if she's
you want your husband to
comfortable.
come in. Don't ask them in front of each other, because if you ask them in front of each other, the wife will be like, if I say that I'm not comfortable with him being there now, he will show me at home. So, but by default, you first of all send one out. First of all, it's you, the doctor, that will invite the second person to come in.
Yeah.
It may not be totally culturally right in our environment, but ideally, that's what they recommend. And it's actually when the other person now said that, in that kind of scenario, now, let's say if we practice that, what will have happened is that the wife initially will have said that, please don't let him enter, please let me know the result first. And then by the time you say it first, she will decide what she wants to do with him.
Tell
She can
him.
go out and say that the doctor says it's not ready, that he misplaced my sample, or say whatever she wants to say.
Yes.
Okay. Now, at that level, at that stage, you did the right thing, totally. Okay, but ideally,
Should have
even for
excused
medical
the man.
consultations. So the time let's say that 16-year-old we discussed earlier, the time the person came and so the person was brought in and said, okay, want to run tests. At that time, as both of them came in. Of course, I'm not sure for minors again, but as I said, 16-year-old is not categorized fully as a minor. So, but let me say the person is even 18 years old now. Let's say 18 years old. Person came in, the ideal thing is so they're okay, that is still wait outside, please. Let me
interact with the patient first.
Interact, find out whether she really wants father to be there. If she said that she doesn't want the father to be there during that conversation, the man should remain outside. At the end of the conversation, you can call the man to come in and just greet him or something. I'm talking ideally now, ideally. Because if in the absence of that, but in certain situations, people will not, you won't get the information you need, and people will not get the outcomes they want. So that's the text, not textbook here, but that's the general recommendation. But we apply it to sense, yeah, as much as possible.
Yeah.
For example, suppose the man is because I really need to go out somehow with something, and also if the test was negative, we don't have access to God.
Okay.
Yes.
So ideally, actually, if it was, that's where this textbook or general recommendation comes into place. So even if it wasn't even a test result, ideally, you should tell the person to go out. I don't tell people to go out, but ideally, you should tell the person to go out. And I mean, my colleagues in UK have given me that scenario over and over again, something they test them for. If two people come together to your consulting room, if you knew together they wanted to be, especially if there's power play, that is one has more power than the other. You should first of all ask your patient to come in, connect to your patient. If he gets to wait outside, you can now, when you certify fully that you want the other person in, you can now say, come in. Particularly for Igbos particularly, because for Igbos, don't know that they're not that family people are like that, not always, and they don't want them to know something about it. You can talk about this part, don't talk about my cancer part. There's a woman that the mother had something, but she doesn't want the mother to know that she has hypertensive heart disease. She brings the mother for consultation, and then when she wants to consult herself with me, she makes sure the mother is already at the pharmacy and stuff. And then my mom was not going to have hypertension because she worry and stuff like that. She doesn't want her mother to. And if I talked about her own hypertension in front of her mother, she won't be happy. So, okay, so that's one part. Now for that one, so ideally, irrespective of that result, ideally,
before you even open her file, the ideal thing would have been to say, I'd like to interact with you first, so that the man doesn't even think it's about whether the result is positive or negative.
Exactly.
I'd like to interact with my guest first, sir, and then we can invite you.
That's the ideal thing. I think that sometimes, I mean, even though we cannot practice that blindly in our environment, but we should be able to judge the time that is necessary. We should be able to just judge the time that is necessary. I do it sometimes too, but we should do it more often.
Some people now get antsy. Even the patient will get angry with you and say, please, I want them to be here.
That one, they will know that she's the one
whatever
that
is happening.
So if you ask the man to go out, like, okay, Oga, please, can you go out a bit? If you want to override you fast, no, it's okay that's fine.
That's fine. We'll discuss everything.
But in situations in which it was the other person that insisted that I want to know what,
no.
She will have said that she will just keep quiet and allow you to ask the man to go out. You will know that, okay, at least
she has handed the responsibility to you.
Exactly. And by the time you now discuss with the person and ask again that you want the man to be in, they will tell you their mind. Okay, but what I've been told over and over again is that if you ask the woman in front of the man that do you want Oga to be inside, she will be forced to say yes.
Yes.
Okay, but if you the center out and then she turned her face away, she gave him you know that she doesn't want this person to be there as much as possible. The situation they described with me before is a situation in which, and it happens, particularly outside the country, that maybe the wife is treating cancer, she's treating something else that is confidential, that she doesn't have to tell that family member, either the sister or her mother. But the woman shall insist to follow her to the hospital on one day. I will follow you there. She couldn't say no at all. They follow that day, but if the doctor sent the woman out, and then she gave the blind eye, so you won't ask her before you send her out, so just send her out. Okay, I want to talk to the patient. But of course, if the woman overrides you, it's overriding you, and then of course, if they break the HIV news in their front, so they can't blame you. Thank you for that.
Thank you.
I think we spent a quality time. I think we should round up now. Any announcements?
This one, let's use this one.